Hello everyone, Dr. Alex Vasquez here with the long-awaited sequel and the next section in our program on human microbiome and dysbiosis in clinical disease. Today I'm going to address the remaining topics and also the upcoming and current presentation. We've covered all the locations and the pathophysiologic mechanisms and the major clinical prototypes. Now we confront the largest reservoir of bacteria and microbes, that is, of course, the gastrointestinal tract. This section on gut dysbiosis will be presented as follows. First of all, we're going to talk about problems specific to gut dysbiosis and the various subtypes of gut dysbiosis. We'll talk about prototypic forms, presentations, patterns of gut dysbiosis, microbes that you must know, and then in the second part of this presentation, I'll talk about solutions, and then I'll have a third presentation where I talk about miscellaneous topics and a few extended conversations on whatever it is I think needs to be included that didn't fit into one of the previous categories. And one of those extended conversations will be on the topic of vaguely mediated afferent perception of dysbiosis eubiosis and the effects that that has on systemic function and systemic inflammation, and specifically on cerebral and brain function and brain inflammation as well. Although I've been writing and presenting on the topic of dysbiosis for more than 10 years, while I could have easily used my previously curated slides, what I did instead is continue to monitor the research, especially over the 2015-2016 research bloom that we saw in dysbiosis, to detect changes in patterns of research and thought. What I've concluded is that my current method of presenting this information is still the most clinically useful, and the most important addition is that of vagal inflammation and vagal anti-inflammation, which I previously mentioned, and which I'll detail much more in one of the upcoming presentations. And then finally, to close out this whole conversation, after this section on gut dysbiosis, I'll deliver a review for the certifying examination, which at this time I anticipate might be a two-tiered examination, one for competence and passing and printing off your certificate if you'd like, and then perhaps a more advanced and more challenging exam for people who really want to become experts and really want to kind of push their own excellence. So what I think is appropriate is for us to collectively, let's say, have a level of competence which indicates that a person studied the material, they attended the videos, and they achieved, sufficient dexterity in the material to qualify for having participated in the presentation in the program. But again, to my own level of comfort, I like to see people try to actually reach for excellence. And so what I think I'll do, as I mentioned here at the bottom, is have a two-tiered exam. One is take the exam, print off your certificate, and you're basically finished with the program at that time. And then perhaps a second exam for people who really want to challenge themselves at a higher level of expertise. I'll see if I can divide the exam in that way, without making it too pedantic, of course. My goal as an educator is to strive and push for excellence, but not necessarily to the point where it becomes burdensome beyond what I think is reasonable for a course such as this. Also, I will print the new slides in what I'm going to call Volume 2. Most of you have Volume 1, which was the printed book originally designed for this course, which also has many of the slides. But I've, of course, embellished many of those slides during the preparation and delivery of this course. And so I'm sure some of you at least want those slides. So what I'll do is I'll make a Volume 2 that has more information, some of the updates, and some of the newer slides that I've added to the program. For those of you who have been enrolled in the program since its inception, as a reward for your patience, just send me an email and I'll send you a copy of that book, most likely printed in black and white. And then everybody will have all of the new slides as well. Again, today we've already gone through the pretest. You all have the printed monograph. That was Volume 1. We've gone through the video presentations. Now we're talking about dysbiosis by location. Our final area in which to focus is the gastrointestinal tract. And then again, we proceed with a review and then the final exam. So again, for this massive topic of gut dysbiosis, I've decided to organize the presentation into at least two parts, mostly focusing on problems and solutions, and then we'll have a few more conversations mostly around vaguely mediated inflammation and anti-inflammation. Notices and disclosures, all this information is copyrighted, of course. It's been published in my books previously. Some of it's protected by trademark and copyright, and the scope of this information, of course, is for licensed clinicians. Disclosure of financial relationships. Most of you know I've worked as a researcher and consultant lecturer for Biotics Research Corporation. Some of the information and some of the drug treatment recommendations that I provide might be considered unapproved by the US FDA, so clinicians will have the ultimate responsibility, of course, to determine the appropriateness of drug prescribing per patient. We will, of course, follow the evidence-based guidelines, and those include patient's preference and autonomy, clinicians' expertise and experience, scientific research, and of course the clinical conditions and circumstances in which we find ourselves practicing. Again, what I'm striving to provide you, and you're going to see this reflected in today's presentation, is what I consider to be a structured approach. Not just a bunch of concepts, but actually how to organize those concepts into something meaningful that you can use in clinical practice and that you can use in your assessment of patients to help recognize which particular pattern of dysbiosis they are presenting with. Dysbiosis is one of the 7 main factors that can influence immune activation, which of course leads to inflammatory disease. So again, we're focusing here on multifocal polydysbiosis. This is a major contributor to immune activation. Again, that leads to just about all of the inflammatory conditions we see in clinical practice, but we need to look upstream in the functional medicine model rather than downstream in the allopathic medical model, just using anti-inflammatory treatments and symptom-modifying treatments. I've organized this into the functional inflammology protocol, recalled by the FIND-SEX acronym. F stands for food, I stands for infection and dysbiosis, N stands for nutritional immunomodulation, D stands for dysfunctional mitochondria and dysmetabolism, S is a larger category including style of living or lifestyle, psychology, sociology, sweat as a metaphor for exercise, stress, sleep, special considerations such as additional supplementation and at times even surgery. The E stands for endocrine or hormonal imbalances, and the X, of course, for toxic or xenobiotic load. If you take the first letter from each one of those categories, it spells FIND-SEX, FIND-SEX. That's my registered trademark for the functional inflammology protocol. We've talked about dysbiosis as a relationship of non-acute, non-infectious host microorganism interaction that adversely affects the human host. Generally, no signs of infection such as fever, redness, swelling, induration, lymphadenopathy, loss of function. And the location of active dysbiosis often has no symptoms or manifestations, and that's particularly true when we look at gastrointestinal dysbiosis. A lot of patients with gastrointestinal dysbiosis will have virtually no major gastrointestinal symptoms, such as what we might see with infectious diarrhea, such as bloody diarrhea, voluminous diarrhea, for example. A lot of patients with gastrointestinal dysbiosis may have no changes in bowel function, neither constipation nor diarrhea, and sometimes they may or may not even have postprandial gas and bloating, which of course is one of the major symptoms that we look for. So again, depending on the pattern of gastrointestinal dysbiosis, they may or may not have any gastrointestinal symptoms. Certainly, in my own clinical practice, some of the patients who have had the most extreme gastrointestinal dysbiosis as a cause, as a direct cause of their inflammatory conditions, have had no gastrointestinal symptoms whatsoever. We've talked about appreciating the role that the total microbial load plays in the genesis and perpetuation of so-called chronic, or what I call sustained, inflammatory diseases. We've talked about laboratory methods. We've talked about the definition of dysbiosis. And with an accurate perception of dysbiosis, we have 3 areas where we can intervene. We can directly address the microbes. We can kill off the bad ones. We can add more of the good ones. We can modulate immune function, that is, promote immune and barrier defenses. And number 3, we can promote immunotolerance, because again, as I've said before, what we see in many of these patients with dysbiosis-induced disease is that they are having an exaggerated inflammatory response to otherwise benign microbes. Location subtypes are listed here. We've got at least 7. Problematic microbes are listed here. I'll talk about some of those again today, and then we've already discussed the molecular mechanisms. This is the overarching structure that I'm presenting to you to help you understand and organize all of this information, and you'll see that structure again represented in our information today. Dysbiosis by location, we have talked about clinical relevance, disease associations, laboratory assessments. Obviously, that just means comprehensive digestive stool analysis with comprehensive parasitology, typically performed over the course of 3 days with 3 different samples. We've talked about microbes and mechanisms, and we've talked also about interventions per location. Again, with the gastrointestinal dysbiosis presentation, which we're starting right now, I will talk about problems in this presentation, and then in the following presentation, we'll talk about solutions. Let's focus on what is clinically relevant and clinically actionable, of course. We've talked about these different locations. We've talked about all of these within this program: orodental, cynorespiratory, genitourinary, tissue and parenchymal, cutaneous, environmental, and now we only have gastrointestinal and endomicrobial dysbiosis to discuss. Endomicrobial refers to microbes that live within other microbes, and we definitely see that within the gastrointestinal tract. So, for example, when we typically think of gastrointestinal dysbiosis, we think of microbes such as bacteria causing that dysbiosis. But what we also need to appreciate is that some of those bacteria, some of those microbes themselves, are actually infected by other microbes, particularly bacteriophages. Bacteriophages are viruses specific to bacteria, and we see alterations in bacteriophage load within the gastrointestinal tract of patients who in particular have Crohn's disease. Now, let's think again of those bacteriophages. Those are viruses that specifically and exclusively infect bacteria. However, regardless of the fact that they target bacteria, it is still a large microbial load, and you can be well assured that some of that viral debris from those bacteriophages does, of course, get exposed to the human immune system, probably absorbed systemically to some extent. And what would you expect the immune response to be against those viral particles? I would reasonably expect that that would result in some level of inflammation. So, for example, again, in Crohn's disease, we see an excess quantity of bacteriophages, and we also see an associated, let's say, inflammatory response, which has hitherto remained so-called idiopathic. But I think as this data progresses, we're seeing that perhaps the overlooked association hasn't been the bacterial dysbiosis, but in fact may have been the viral dysbiosis. We've talked about various mechanisms listed here. I've gone through all of those with you in the printed monograph and or in this presentation series. Now let's focus on gastrointestinal dysbiosis. GI dysbiosis is the most varied and quantitatively the most important. All of us have somewhere between 1 and 1.5 kilograms, that's 2 to 3 pounds, of microbial mass. So just think of that. Think of anything that you could encounter, such as a weight or a book or something like that. A large book might weigh about 3 pounds. Think of that level of mass of bacteria within your gut. As many authors have said before, it's about the size of your liver. So imagine an external microbial organ, so to speak, as part of your own body. That would be the gastrointestinal microbiome. Even when patients have a triggering dysbiosis in another location, let's say in the nasopharynx, they nearly always have an inflammatory predisposition, let's say, set up, or an inflammatory stage set up by the events that are occurring within their gut, which powerfully influence immunophenotype balance. So let me say that in a different way. What I want you to understand is that the inflammatory stage, or the inflammatory predisposition, or the inflammatory phenotype gets established by gut dysbiosis and then can later be triggered by nasopharyngeal or orodental dysbiosis. I want everybody to be clear on that. So, for example, in ANCA vasculitis, we talk about nasopharyngeal dysbiosis. Well, I think what you're going to see as the research progresses is that those patients have an associated and contributory gastrointestinal dysbiosis that contributes to, or we might say, kind of fuels the fire, which is later then sparked off by the nasopharyngeal dysbiosis. And I believe very clearly that the same occurs in rheumatoid arthritis. So, for example, when we look at orodental dysbiosis in rheumatoid arthritis, we see that those patients have orodental dysbiosis, which is molecularly and, in my opinion, very clearly linked with their pathophysiology, because we appreciate that within their orodental cavity they have a specific bacteria that produces an enzyme which alters human tissues in such a way as to contribute to the production of those anti-CCP antibodies. So I think we've got a really clear pathophysiologic link there, but I think that the immunophenotype predisposition is established from gut dysbiosis, later triggered by dysbiosis in other locations, especially the mouth. We've talked about gastrointestinal dysbiosis, such as small intestine bacterial overgrowth. We see that in fibromyalgia. We see that in several different inflammatory diseases. We also see that in metabolic disease, such as diabetes mellitus and insulin resistance. Our assessments are history and physical exam. So, for example, your most important question in your history is to investigate for postprandial gas and bloating. That is the primary manifestation of small intestine bacterial overgrowth. They may or may not have diarrhea, constipation, but they always have, virtually always have, postprandial gas and bloating, or they may have modified their diet in order to avoid postprandial gas and bloating. So the question you ask in your history is, if you eat a high carbohydrate meal, such as potatoes, pizza, wheat, bread, pastry, dessert, perhaps even lactose or dairy products for some patients, if you eat a high carbohydrate meal, do you get gas and bloating? If they say yes, you can be reasonably assured that they have small intestine bacterial overgrowth, because the human body has no organ in the gastrointestinal tract to produce gas. If they have gas, it's coming from the bacterial fermentation of carbohydrates. Now, if you ask that question and the patient says, no, I don't get gas and bloating, then you have to ask, did you modify your diet to avoid gas and bloating? And at that point, a lot of patients will say, oh yeah, I've kind of forgot about it, but many years ago, I learned that I have to avoid things like fruit juice, onions, potato, dairy products, wheat products, because if I eat those things, I feel horrible, my joints flare up, and I get gas and bloating. So a lot of times, these patients will have basically treated themselves through dietary modification to avoid the pain and the discomfort that accompanies the blossom that occurs in their small intestine bacterial overgrowth after they consume a high carbohydrate load. Breath testing is used by lots of doctors. I'm more or less against it for a couple of reasons. First of all, we used to use the hydrogen test, then we used the hydrogen and methane test, but as far as I know, no one's testing for hydrogen sulfide. And the ultimate product of bacterial fermentation and metabolism is often these sulfur-containing compounds. And if the lab's not testing for them, then obviously they're going to miss it. The test could come back negative when, in fact, a patient has a sulfur-reducing dysbiosis, not a methanogenic or hydrogen-producing dysbiosis. I think all of us agree that stool testing is a good idea. I think that that test can be overused at times. I think sometimes we can just treat these patients empirically. However, we always have, and a lot of times we need to rely on stool testing for a more accurate assessment of what is actually occurring. We are going to talk about the major and non-exclusive types of gut dysbiosis. What I mean by major is these are the major patterns, but they're non-exclusive, meaning that patients can have more than one pattern occurring at the same time. So at the very least, what you need to be able to do is appreciate each individual pattern, and then in your patients, you can look at them and say, wow, you've got an overlap, commonly, for example, of insufficiency dysbiosis with an inflammatory dysbiosis. So in this list, that would be category 1 and category 5. A lot of times they'll have category 1 associated with something else. So for example, they can have insufficiency dysbiosis with a neurotoxic or neuroinflammatory dysbiosis. So these are not exclusive, but again, these are the major patterns that we see in clinical practice. Let's look at that list again here, much larger, of course. Major non-exclusive types of gut dysbiosis: insufficiency dysbiosis, bacterial overgrowth, small intestine bacterial overgrowth, or what I prefer to call small intestine microbial overgrowth, because some of the overgrowth that we see is actually yeast, not specifically or exclusively bacteria. Immunosuppressive dysbiosis, hypersensitivity or allergic dysbiosis, inflammatory dysbiosis, and then we look at kind of more microbiologic or pathologic colonizations or perhaps even infections, amoeba, cysts, protozoas, other parasites. Metabolic and dysmetabolic dysbiosis, again, we see that with diabetes mellitus and insulin resistance. Also a very clear neurotoxic dysbiosis, for example, in patients with autism, and also a neuroinflammatory dysbiosis. I think we're going to see this more and more relevant for multiple sclerosis, as well as chronic pain syndromes, such as fibromyalgia and chronic regional pain syndrome. Many clinicians do find comprehensive stool analysis and comprehensive parasitology to be among the most valuable laboratory assessments they utilize, perhaps second only to basic lab tests such as CBC, CRP, UA, and of course the chemistry metabolic panel that we're all familiar with. Again, to the right of this page, you see some problematic microbes. I have reviewed those with you previously in a video, I believe it was perhaps video number 4, and I'll talk about some of those again here today in a different format. One of the points that we all need to be aware of is that routine hospital and medical lab testing is generally not detailed enough. So a lot of the markers that we're looking for are simply not going to be reported if we use a hospital lab or a standard medical lab. What those labs are looking for are the classic pathogenic causes of gastrointestinal distress, namely gastrointestinal infections such as Salmonella, Shigella, and enterohemorrhagic E. coli. They might look for other microbes such as Endolyne mixnana or Entamoeba histolytica, but a lot of times they will not look for those other microbes, and they specifically are not going to look for inflammatory markers and the immune markers that are very, very important for putting all of this into context. So we need to use one of the functional labs, of which we have several to choose from these days. Some have